Thank you again for the kind invitation. So today we will talk about the humeral head resurfacing in the treatment of shoulder osteoarthritis. As you know, glenohumeral osteoarthritis is a symptomatic pathology of the shoulder with pain and physical limitation. The prevalence is almost from 4 to 26%, affecting nearly a third of the world's population over 60 years of age. The treatment options are different and are based on the patient's age, severity of symptoms, level of activity, and radiographic findings and medical comorbidities. And we can choose from non-operative treatment to operative one. Joachim depicted now the different kind of prosthesis, and the design ideated by Charles Neer in 1950, designs evolved during time to better reproduce and accommodate the individual shoulder anatomy. And during this evolution, as we said before, implants have transitioned to shorter humeral stem, and in 2004, thanks to Dr. Steve Copeland, was developed the stemless component. The objective of the aim of the humeral head resurfacing was to restore the patient's individual humeral head anatomy, such as articular retroversion, neck shaft angle, lateral offset, and center rotation, and to preserve the bone stock for a possible future revision surgery. The criticism of this implant is it's not easy, but it's not simple. It appears simple, I think. It's the failure of the implant. In fact, the correct positioning of the incising and the orientation of the prosthesis is fundamental to prevent glenoid wear. So the aim of the study was to evaluate the medium-term outcomes and survival of a specific cementless humeral head resurfacing in a group of patients that I had operated in the single center where I work. 23 patients were enrolled for the study, and in 2 patients who was implanted bilaterally. So we have enrolled 25 shoulders between the period from in 5 years between February 2009 and May 2014. The indication was primary osteoarthritis in 15 cases, in 15 shoulders, while in 10 shoulders we had a humeral head avascular necrosis. The exclusion criteria were the presence of a rotator cuff tears, both or partial or complete, and in case of the glenoid was damaged. The mean follow-up was almost 7 years. All the patients were evaluated clinically and radiologically in the pre-op and with the X-ray and the MRI to evaluate the grade of osteoarthritis and the grade of vascular necrosis. Postoperatively, the X-ray were performed to evaluate the signs of loosening with a radiolucent line and the appearance of the genetic changes and the vertical humeral migration over the head. So about the results, we refer to 19 patients with 21 shoulders that completed the follow-up. And if you have a look, all the results referring to pain, to constant score, the VAS and the active ROM improved during the time and remained stable. 4 patients were lost because of prosthesis failure, and as you can see in the table, in 3 cases we had glenoiditis, and in 1 case an old woman that fell and had a traumatic rotator cuff tear. The glenoiditis was observed in 3 cases. In 1 case, the rotator cuff tear, and we can see how the superior migration of the humeral head. All the revised cases, the implant removal was performed without any complications, and as you see in the picture, it remains a sufficient bone stock for the reimplantation. In 3 cases, we had converted the implant in a reverse prosthesis. In 1 case, we have implanted a total shoulder arthroplasty. If we have a look to the results with the postoperative X-ray changes, we don't find no signs of loosening, but we had the appearance of osteophytes in 12 cases on the glenoid side, and in 7 cases on the humeral one. And in 11 cases we had a glenoid erosion. In 8 cases it was asymptomatic. In 3 cases symptomatic, then was revised. The global revision rate was 16% at a mean follow-up of 7.4 years, while the survival rate was 84%. So in conclusion, this type of prosthesis is not easy. It's require a surgical indication really precise, because we have to evaluate the integrity of the calf, the good bone stock to fix the implant, and the healthy glenoid. The surgical technique is really precise, in particular when you have to size the head and orient it, because an incorrect assessment may produce an overstuffing of the joint, and so may produce the failure of the implant. If we have a look to the current literature, the reported incidence of the humeral resurfacing failure rates in the literature compared with our study is similar. And the problem was the glenoid. In literature, there were a lot of attempts to prevent the glenoid erosion, and with a biological approach, and different tissue were employed, the anterior shoulder capsule, the Achilles tendon on the fascia lata, and the lateral meniscus, but all these attempts failed, because the failure rate reported was from 56% to 70% in all cases. So the weak part of the shoulder, we can conclude that is the glenoid. If we have a look in the total shoulder arthroplasty, the glenoid component loosening and failure represent the most common long-term complication of total shoulder arthroplasty. And the results of a shoulder replacement highly depend on the status of the glenoid, be it native or implanted. So probably we have to work on that side. Thank you for the attention.